Hi everyone, welcome to our live webinar tonight. I'm outside the Greenbrook office here in Palm Beach Gardens, Florida. Why don't we go inside and take a look? So hi, I'm Trevor Seck, a Senior Director for Neuronetics and Greenbrook Mental Wellness Centers. I'd like to welcome you to our Greenbrook Gatherings webinar series, where today we're going to show you how Greenbrook can expand your patient care options, and we're going to take a look at what a patient consultation looks like, as well as some of the pre-assessment process with Dr. Poole for both NeuroStar TMS as well as Spravato esketamine. So before I get into that, I just want to talk a little bit about Greenbrook. So Greenbrook is transforming mental health care, and how Greenbrook is the nation's leading advanced mental health provider focused on rapid access to care for both MDD and OCD patients. Now, they typically specialize in NeuroStar TMS and Spravato esketamine. I am at one of the 95 centers that are located across the United States in over 15 states. They've provided care for over 57,000 patients, and they have over 10 years of experience at all of these locations. And we've delivered over 1.9 million treatments for both TMS as well as Spravato. So what I'd like to do real quick is just give you a quick tour of the office here in Palm Beach Gardens. For many of you that are live in a variety of locations, you'll know that many of the Greenbrooks are set up very similarly. We've got the welcome sign. We've got a reception desk here where patients can check in digitally on an iPad. We've got a few tables here where they can wait, as well as a little bit larger waiting room here where they're able to take a seat while they wait for their treatments. We've got a mini fridge over here on the wall that's full of refreshments, and you've got a number of literature items. There's some candy set out here for us, as well as a coffee stand. So obviously we want patients to feel warm and welcome whenever they come into a Greenbrook center. There's plenty of reading materials, a TV here in the waiting room, so you can see this is definitely a warm and inviting space. So before we dive into some of the treatment rooms, what we're actually going to do is take you through what a consult is with one of our consult coordinators. So why don't we come on down here? I think Savannah is waiting for us. Hi, Savannah.
Hi, Trevor.
So nice to meet you.
Nice to meet you. I'm a consult coordinator here at Greenbrook. And essentially, what I do is I provide options for patients, and I can't wait to show you what makes Greenbrook special and why partnering with us can make a huge difference.
Awesome. So should we take a step in your office?
Of course, let's go.
Show them what a consult looks like for the patients. So Savannah, tell us a little bit about what makes Greenbrook different from some of the other advanced mental health providers out there.
I'd love to. So let's really start with what makes Greenbrook very different, right? At the heart of everything we do, there's three things: convenience, collaboration, and compassionate care. First is the convenience. With over 95 centers across 15 states, we make it easy for patients to get care close to home, because let's face it, if it's not convenient, it's harder for patients to stick with. Second is that collaboration aspect. We believe the best care happens when we are all working together. That means keeping patients connected with their providers, and then making sure you're always in the loop as well. And we do coordinate smooth transitions so your patients stay supported every step of the way. And finally is that compassionate care. We're all about making the experience as seamless and supportive as possible. That means fast-tracking consultations, reducing delays, and ensuring every step feels supportive and respectful to the patient. From the first call to the last session, our goal is to make sure patients feel seen, heard, and cared for.
Now, Savannah, I know that the consultation is a very important part of the patient journey, but could you walk me through what the patient journey looks like at Greenbrook and how fast and rapid you guys give access to care to those patients?
Of course. So, what does that look like in action, right? Let's walk through the entire journey. It starts with quick scheduling. As soon as we get the referral, our team calls the patient right away and to set up a no-cost consultation. That speed really does matter for the patients because it helps reduce anxiety and keeps things moving forward for them very easily. Next is the actual consultation itself. This is where patients learn about treatment options while we handle all the insurance details. No hassle, no confusion, just clear, straightforward information. Then comes the pre-assessment. A Greenbrook provider meets with the patient to ensure treatment is a right fit. It's thorough but also compassionate, and most of all, ensures patient safety. Finally, if the patient is a candidate, we move forward into treatment with a personalized plan. Our providers make sure everything is tailored to their needs for the best possible outcome.
Awesome. Well, I think this is going to take us into our first audience poll. So for many of you that are live right now or at our awareness events, obviously one thing I will tell you is that for you at the live awareness events, I believe many of the local consult coordinators are also in attendance. So if you get an opportunity, I'd be sure to ask them some questions and see kind of what it's like and how they handle the patient consultations at their Greenbrook Center. But our first poll, if you've got your phones and you're ready to go, or if you're at one of the awareness events, please yell out your answer to the regional area manager there that's supporting it. The first poll is, when patients start treatment at your practice, who is the first team member they meet? Now, your answer options are a provider, a practice coordinator, billing, or insurance specialist. And now we'll go ahead and give you guys a few seconds to answer that, but just a few. So quickly grab your phones and get those answers in. All right, well, I think that was enough time. Savannah, can you see the results?
I can. With an astounding 89%, we have a practice coordinator.
That's fantastic. So they're definitely familiar with that.
Love it.
So why don't you tell us a little bit about, Greenbrook and the consult coordinators?
Of course. Now, that's my favorite part. I'm a little biased. The role of a consultation coordinator includes myself and our amazing team here at Greenbrook. After the intake schedules the initial consultation, we step in as the patient's main guide. We confirm insurance, explain any financial details up front, and handle scheduling so everything runs smoothly. But honestly, our most important part of our job is being a friendly, reassuring voice. We answer questions, provide support, make sure patients feel cared for every step of the way. Think of us as the bridge that keeps everything connected and seamless.
That's awesome. So, tell me a little bit, and pretend I'm a patient, like, what is that consultation experience like?
Of course. So the actual consultation itself is simple and flexible. We can meet patients in person, over video, or even by phone, whatever works best for them. And always, it's at no cost. During the consultation, we give a clear overview of treatment, review the medical history, and take care of all the insurance details. That way, patients can truly focus on knowing their options versus the paperwork. And when it's done, we handle the next step, which is scheduling a pre-assessment with one of our providers and all the follow-up in between. So the process keeps moving forward without delays. And as always, our goal is to make the experience as comfortable and effortless as possible for the patient.
And I'm really excited about that pre-assessment process, because I believe we're going to do that in just a few minutes and get a little bit of a reveal on what that's like. But, if I were a patient and, we were here together doing a consultation, I think the number one question that would come to my mind is, does my insurance cover it?
Absolutely. So let's talk about that coverage. Typically, one of the first things we will hear as a consult coordinator is, what does my insurance cover, right? Straight to the point. We all know it's a huge concern for our patients, right? That factors into if they can do treatment. Here's the great news. NeuroStar, TMS, and Spravato is covered by most major insurance carriers, including Medicare and TRICARE. In fact, more than 300 million people in the US have insurance that includes NeuroStar, TMS, or Spravato coverage. We have some familiar names, Aetna, Anthem, Blue Cross, Cigna, Humana, and so many more. And for patients whose treatment maybe isn't fully covered, we do accept organizations like CareCredit. They offer financing options to help with co-pays, deductibles, or even full cash pay if needed. Of course, every plan is different, so we always check benefits and eligibility, but overall coverage is widely available, which makes it so much more accessible for our patients.
Now, what I love about that, Savannah, is that you said Greenbrook covers and manages all of that. So for those of you that are considering referring any patients to a Greenbrook Center, you don't have to worry about, does their insurance, cover TMS or Spravato? You shouldn't have to worry about any of that. You can refer them over to Greenbrook, and they'll take care of all of those insurance steps. So
Absolutely.
I think that's fantastic. So Savannah, one of the things you mentioned and we talked about it was the pre-assessment with Dr. Poole, and I was wondering, is he available tonight?
Absolutely. So if you're a patient, there are many days where consultations take place and we can do a same-day pre-assessment. And it looks like Dr. Poole does have the time today to do that and show you what that looks like.
Fantastic. So before we step into one of the TMS treatment rooms, I just wanted to quickly introduce Dr. Jacob Poole, who joined Greenbrook back in 2023. He's a psychiatrist for both the Palm Beach Gardens location as well as the Point St. Lucie Greenbrook centers here in South Florida. He's also board certified in psychiatry and neurology, specializing in depression, anxiety, and neuromagnetic medicine, which we're about to experience and see in just a few minutes. And he's treated over 200 patients here at Greenbrook with both NeuroStar TMS as well as Spravato, and he's provided over 7,000 individual TMS treatments. So with that, Savannah, why don't we head over to one of the NeuroStar TMS rooms?
Love to.
All right, come on.
Welcome to our NeuroStar TMS treatment room, and here's Dr. Poole.
Just so happens to be right next door. So you can see in this giant TMS room here, it is definitely warm and welcoming. There is a TV up here. If you can pan over, there's a TV up in the corner for the patients to watch while they're undergoing treatment. Plenty of art, some special notes from some of the patients on the table here. And what I love is that there is this really nice couch here for any family members or friends of patients that want to join them during treatment. But I'm not going to give any more away. I'll let Dr. Poole go ahead and show you and talk a little bit about NeuroStar TMS.
Well, hi, I'm Dr. Poole. I tell patients like a swimming pool. It's nice to meet you. Right now, I am sitting next to a TMS machine so that you guys can see what one looks like. Hopefully this is pretty informal. We have some frequently asked questions about treatment. I'm going to try to answer those as best I can. Okay, first up, what topics do you typically cover during your first meeting with a new patient? This is a poll for everyone, so we're going to give you some time to answer. Okay, I think we've got some answers coming in. So this first meeting is also known as the pre-assessment or provider evaluation. My first questions here are always about safety. We'll go over your medical history together. We'll make sure that you don't have any contraindications to treatment or reasons that treatment might have extra risk. Second, we'll complete a full psychiatric history and physical. It's where we ask about your life, your stress, your symptoms, and your treatment so far. While of course we focus on current symptoms, we also screen for less common ones like those in bipolar disorder or PTSD. It's important for making the correct diagnosis, but also just for getting a good sense of what your baseline is before treatment begins. As I follow you during treatment, we'll continue to make direct comparisons to this very first visit. Thirdly, we talk openly about treatment options. TMS, for example, is a non-invasive procedure, so we talk about the pros and cons, the indications, expectations, benefits, risks, and alternatives, just like we would for any other procedure. I like to say that no mental health treatment should exist in a vacuum. If you need a referral to a local PCP, psychiatrist, therapist, one of the core tenets of our treatment model is that we exist as a supplement to those providers here in the community. If you need a referral, we're glad to make one. We also just examine you as a human being. If you're not getting enough sleep, if you've fallen away from activities that give you joy, or you have serious external stress, we talk about how to pay attention to those things too. When we are both out of questions and most likely exhausted, we'll choose together which treatment options fit you best. Next question, what is TMS? This is a Dr. Poole question. TMS stands for transcranial magnetic stimulation. It's a technology. However, when used in a certain way, it's also an FDA-approved treatment for illnesses like depression. It's pretty easy to explain. This coil produces a very powerful magnetic field, similar in strength to an MRI. That field is spherical in shape, and it's about the size of a plum, but I can't make my hand that small. We lower this magnetic field beneath the skull, and we stimulate a very specific region of the brain called the dorsolateral prefrontal cortex. It's a big word. I think the main thing to remember is that it's the brain's primary mood regulation area. It plays a critical role in depression and in anxiety. Keep in mind this is still only a magnetic field, so it can pass through hair, skin, and skull harmlessly. There's no need to cut you or to use anesthesia. Most patients watch TV or listen to music during treatment. Next question, how does TMS help depression? The TMS field directly increases brain cell activity. That means the neurons under the influence of that field will fire faster and more often, both during and after treatment. This also has a downstream effect to deeper areas of the brain, which play additional roles in emotional processing. Higher activity in these areas can result in improvement in the symptoms of depression. In addition to that, TMS increases neuroplasticity. That's the ability of the brain to grow and change. I mean that literally. As you rest and recover between treatments over some days and weeks, the target area should become slightly larger in volume over time and become more active on its own. This structural change likely explains the long-term effects of TMS and why most patients who remit stay in remission for years after treatment ends. How is TMS delivered? It's the next slide. For depression, patients receive 36 daily treatments. These are short, about 19 minutes each. It's all performed outpatient. You are awake and alert. You can walk in and out. You can eat food. You can drive home. Many patients fit TMS into their lunch break or before or after work. Still, 36 treatments is a big commitment. It's why I think talking about the science together matters. This volume of treatment is really just a good average for producing the best short and long-term results from TMS. We have a poll question. It says, based on a recent study, what do you think the response and remission rates are for TMS? Again, we'll give you some time to answer on your own.
And the options for answers will be 83%, 62%, 75%, 50%, 38%, 26%, or if none of those fit the mold, you may be unsure.
Looks like some answers are coming in.
Yep, so we're definitely seeing the highest response at 83% response, 62% remission.
Well, I'm impressed by that.
Yeah.
After completing treatment, we expect response, meaning more than 50% improvement, in about 70 to 80% of patients. We expect remission, meaning minimal or no symptoms remaining, in about 40 to 60% of patients. The study on the screen completed in 2020. It features over 5,000 patients across more than 100 clinics treated with NeuroStar TMS. These numbers are encouraging. It doesn't include everyone, but it is correct to say that most patients who get TMS benefit. That has been my life for the last few years. That was not my success rate back when I was a daily medication prescriber. What's most exciting to me is that the majority of this data on TMS comes from studies in treatment-resistant patients. From landmark studies like STAR-D, we know that that third, fourth, fifth medication you try has diminishing returns. I'm sure that you guys see that play out in your clinics every single day. TMS in this same group is more successful. That's my argument to you. If you'd like more data, there are hundreds of studies on TMS. We'd be glad to send some key articles your way. Who may be a candidate for TMS? This is the next question. If you only remember one thing from today, I hope that this is it. TMS has gained significant scientific ground since most of us have graduated. It is now FDA approved for adults with depression who have failed one or more medications. It is now also the official recommendation of the APA that TMS be considered at that time. That is much earlier in the treatment hierarchy than I think most psychiatrists are aware of, and it reflects the building evidence supporting TMS. TMS is also FDA approved for adolescents ages 15 to 21 as an adjunct treatment. Let me say that again, ages 15 to 21. This is a huge area of need where only a few medications are FDA approved, and many children and parents prefer a drug-free option. This new standard for TMS also just applies to a lot of people. About 2/3 of patients with MDD are not satisfied with their current treatment. About 1/3 are considered treatment resistant. So in my practice, if a patient has failed a medication or two, I am no longer providing the standard of care if I'm not also considering other evidence-based options like TMS or like structured therapy. TMS is also a drug-free option for patients more vulnerable to side effects, children, seniors, complicated medical patients, or patients who simply aren't interested in daily medicine. I'm sure we all see those folks. Although today is more of a brief overview, NeuroStar TMS is also FDA approved for 2 additional psychiatric indications in adults. These are MDD with co-occurring anxiety and OCD. All indications have unique target location, protocol, and dose. Who is not a candidate for TMS? Well, there's only one absolute contraindication. You can't have any magnetic metal in your head or your neck. Why? Well, the TMS field could potentially move or heat that metal. But it doesn't mean all metal. Most titanium, which isn't very magnetic, is fine. Most modern dental hardware is also fine. So in reality, it's more of a careful clinical decision, and sometimes we do a lot of looking up too, just to make sure. There are also a few relative risks we consider. That means you'll probably still be able to have TMS, but it's important for me to get more information first. I always ask about stroke, brain tumor, seizures, serious head injuries, or metal in the chest like a pacemaker. Next poll, do you think TMS is safe? We'll give you some time to answer that.
And the answer options are fairly simple this round. You've got yes, no, or maybe unsure. And we've gotten plenty of responses in, and the resounding answer is yes.
Okay. The short answer is yes. The longer and I think more doctory answer is that no treatment is without risk. So kind of a trick question. What do I mean when I say that? Well, with TMS, I don't worry about those common systemic side effects you might see from medications for depression, like fatigue, weight gain, sexual problems, the list goes on. There is no chemical component to TMS. It's not in the stomach, bloodstream, liver, or kidneys. It's not attaching to unintended receptors all over the body. Instead, TMS stimulates the brain directly, and it's that stimulation that might cause issues. The most common issue is some discomfort at the scalp or the upper face. This is because the scalp is full of tiny nerves. Now, those nerves have nothing to do with depression, but they're in the way of our magnetic field, and they get stimulated just the same, causing small muscle contractions. Sometimes the movements are even visible. The most important thing to say from my point of view is that this is expected and not dangerous. It varies in intensity from people who say, you know, Dr. Poole, I stayed up all night, worried about this is nothing, to people who say, ow, okay, you're right, can we lower the power? We can and we do. You being comfortable is a major priority. Along the same lines, we monitor for any headaches during treatment. These are caused by overuse of those small muscles, like when you give yourself a headache from straining your eyes. If they happen, they're usually isolated the first week or two and they're mild. A little bit of ibuprofen in time goes a long way. Like an MRI, TMS clicks. Can you hear that? As the magnet cycles. In clinical trials, you have patients wear hearing protection just in case, and we recommend the same here. We provide you with a new set of earplugs every day if you wish to wear them. We promise to turn the TV up if you can't hear it. Seizure is one of the scariest, but also rarest potential side effects from TMS. With proper screening, modern devices, and standardized protocols, this risk is estimated to be very low, something like 0.0003%, so not expected to happen to you by any means. Still, we think it's worth screening for, telling you about, and preparing for, just in the rare event that it might happen. Finally, like any treatment for depression, even when symptoms are improving, it's always important to monitor for any negative changes in mood, thinking, or behavior. These are fortunately also rare. One of the best features, I think, of our clinic is the ability to see and monitor patients daily. If concerned, we can always just take a break from TMS and simply assess where you are. Next, what can I expect during treatment? So we're gonna show you, hopefully. I've got Trevor coming in as a patient, and I will extend the chair here into the TMS mode.
And I just want to let everyone know that this is for demonstration purposes only, and NeuroStar TMS is by prescription only. So, you know, what we're going to be demonstrating here is a motor threshold.
NeuroStar Advanced Therapy is by prescription only. This demonstration is for training purposes only and not representative of an actual prescription MT. Patient prescriptions, outcomes, and experiences will vary. The most common side effects include temporary pain or discomfort at the treatment location and/or headache. There is a rare risk of seizure, less than 0.01% per patient. Please refer to neurostar.com for full indications, contraindications, and important safety information.
And what your patients can expect. So I'm excited. I've got my MT cap. I've already got on and ready to go. So maybe you could explain what the MT cap is for.
Yeah, I sure can. Okay, on your first day, let me hang this up. On your first day of treatment, your physician will map you. This is where myself, staff, and the patient work together to make sure that 100% of the treatment is delivered at the right location, depth, and dose. I will admit, Trevor's wheels have been greased a little bit. We already have some idea of where his motor cortex is from earlier. If we didn't, no big deal, probably would take a few minutes and maybe you'd be bored. Okay, what we're going to do is, the machine is definitely on. We will start.
You guys can come closer too and see if you can see my hand move.
Here, where we think his motor cortex is, and we'll fire some pulses there looking for movement in his right hand. Remember, left motor cortex, right hand. If it works like it should on the brochure, it would be a movement of the index finger or thumb, sometimes a perfect pinching motion like that. Let's see if we can get something. Okay, I think you're already seeing it. Again, we cheated a little bit, but I think you can already see it. Okay, So we're getting a nice movement of the hand and definitely some of the thumb and index finger, just like we saw earlier. Are you able to see that, you think? Oh yeah, we can see it. Okay, just wanted to make sure that the audience could see what I was talking about. All right. Once we locate this landmark area, we'll do some functional testing to determine the correct power level, and we'll save these measurements from Trevor's chair, his head, and the coil into our computer system here. These measurements will stay the same throughout treatment. They help to maintain the positional integrity. We'll then move to a few centimeters forward to our actual treatment area. That's the dorsolateral prefrontal cortex as promised. When treatment begins, pulses will fire faster. That was the snapping I was doing earlier. They come at 10 beats per second or 10 hertz. We stimulate for 4-second intervals with 11-second breaks for 3,000 pulses, and up to 120% of this initial power level we'll find here. This protocol comes from decades of research on the best way to stimulate this target area. Finally, I just want to talk about, we'll get this off of Trevor for a moment. Sorry.
Yeah, that's great.
What kind of care can I expect to receive, right, during and after TMS? Personally, I follow with patients pretty often. I want to do that early in treatment to make sure that they're tolerating treatment okay, but I also want to do that periodically in more formal visits. During these visits, my job is to compare symptoms from our first interview to symptoms now. What's better and what's left? We'll also take a look at survey scores the patients complete each week and use data points to make smart adjustments to treatment, maximizing your opportunity for benefit. Finally, after you complete TMS, we'll follow up at least one more time. We'll talk about final results, how best to target any remaining symptoms, and how to maintain good mental health for as long as possible. Okay, Trevor, give us a scoop. How do you feel?
I feel great. I feel like normal, but I mean, it was just a light tapping. You know, but it made my hand move, so it's fun science. But I do have to ask you one question. Do I have to wear the cap every treatment?
No, you can if you wish to, but you do not have to.
I don't have to.
In fact, everybody gets a new cap, so you can take it home with you, go swimming, go to the shower.
Awesome. So tell me a little bit about this. I know we just covered NeuroStar TMS, and we appreciate you doing that. What about the other treatment option that Greenbrook offers?
We do. We have something called Spravato, which leads us to our next poll question. Has anybody heard of Spravato?
So we're going to go back up to the slides and ask the next poll question while we walk down the hall to our Spravato treatment room. So we'll go ahead and get those results in and start heading down there. Dr. Poole, if you want to join me. Each one of these rooms is a private space for every patient, so they do get a little bit of privacy, which is neat. And in this center right here, we've got 3 different treatment rooms, and so we've got a very comfortable patient chair right here where I'll go ahead and take a seat. And so let's take a look at the polls. I would say it was a resounding yes. About 78% have heard of Spravato, which is fantastic.
Well, that is good news. So what is Spravato? Spravato is intranasal esketamine. It's a non-daily FDA-approved medication for depression. It's different from traditional medicines in several important ways that we'll talk about. The first is obvious to anyone who sees it. It's not a pill. It's a nasal spray. Spravato goes into the nose, and it's absorbed directly into the bloodstream from there through the rich network of blood vessels that exist in the nasal mucosa. How does Spravato help depression? Spravato targets a completely unique receptor in the brain. It's called the NMDA receptor. It's located on brain cells, which normally inhibit another pathway called the glutamate system. Increased glutamate signaling has an overall activating effect on the brain's mood centers, and like TMS, leads to a measurable increase in neuroplasticity. That's the brain's ability to create new proteins, cells, and synaptic connections. We're still studying exactly how that process happens, not just in the case of Spravato, but because it's important, and may be a key step to improving other conditions like dementia. How is Spravato dosed? I think we have a slide on that. So Spravato has 2 available dosages, 56 milligrams and 84 milligrams. In my clinic, we typically start with the lowest dose, at least for the first treatment. We can always go up if you tolerate it well. Another key difference between Spravato and traditional medications is how often you take the medicine. I said it earlier, Spravato is a non-daily treatment. We start with what's called the induction phase. That's 2 treatments per week for 4 weeks, 8 treatments total. The purpose of this phase is to give the medicine time to work and for you to see what you think of it. If it's not for you or it's not helpful, we'll of course talk about other options. However, if you are in the majority and it is helpful, we can move forward to what's called the maintenance phase. Here we treat less frequently, just once per week or once every 2 weeks with the purpose of maintaining that good response. Next poll question, based on real-world evidence, what do you think the response and remission rates are for Spravato? Give you some time to answer.
And your options are 69%, 52% remission, 43% response, 23% remission. I think we've got one of the most educated audiences out there. We're seeing the majority are saying the 69% response, 52% remission.
Well, it was supposed to be tougher than that.
Yeah.
These numbers are from a single study that you see on the screen now. Obviously, these are promising. I would say, however, that a good average of many studies puts the response rate of Spravato at something like 50 to 70%. Remission rate, or the percentage of patients who after treatment have minimal or no symptoms, is effectively a little bit lower than that, about 30 to 50%. But the headline is a similar one to TMS. Most patients benefit. Another key difference between Spravato and traditional medications is when you might see results. Results are expected by the end of that 4-week induction phase. That's compared to 6 to 8 weeks, which is classic for traditional medications. Something else we see across multiple studies, and certainly anecdotally here in our clinic, is that a subset of patients report benefit in as little as 24 to 48 hours. Next question, who may be a candidate for Spravato? So Spravato is FDA approved for adults with treatment-resistant depression. This means that 2 or more medicines have not been successful. There is an exception to this. Spravato is also approved for adults with suicidal ideation or behavior. In this event, you do not need to have failed other medications. That's important to know. I see this as having specific impact for patients under inpatient care, patients in the hospital, patients in a daily program like a PHP or an IOP, or simply folks who are simply severely ill. Spravato's potential to act faster, in some cases almost immediately, could decrease disability, save lives. In previous years, Spravato had to be used as an adjunct treatment. Now that has changed, is FDA approved as monotherapy. Who is not a candidate for Spravato? So Spravato has 4 absolute contraindications. The first is pretty self-explanatory. A history of allergy to Spravato or other ketamine-derived products. The other 3 are conditions that could be dangerous if the patient were to experience a transient increase in blood pressure during treatment. These are a history of intracranial hemorrhage, aneurysm, or AVM. Also, for now, I don't advise treating patients who are pregnant or breastfeeding. We simply don't have enough data to make conclusions about safety under those parameters. Can Spravato cause side effects? Yes. It's another difference, though, between Spravato and traditional medication. The side effects you might have look scary on a list, but they're not typically happening on a daily basis or at home. Instead, they tend to occur during this 2-hour treatment window, just after treatment begins, when the medicine is peaking in your system and then coming down almost as quickly. In fact, we are required by a federal REMS program to supervise patients in office during those 2 hours. We try to make the process as pleasant and as unintrusive as possible. I don't know if you feel it's been unintrusive, Trevor. Patients have a nice private space, a big armchair.
It's very cool, I have to say. Yeah, wish we could do Q&A in here.
We monitor via camera from a room off to the side. We check on you several times. You have a call button just in case. You can bring a friend, listen to music, watch your phone, or nap. There's a lot of napping while we do our job. During this period, we monitor for side effects. So what are those? Sedation, feeling tired or sleepy. Dissociation, these are mild sensory or psychedelic effects. Dizziness, unsteadiness, nausea, anxiety. Transient increases in blood pressure or any misuse. We will measure blood pressure before, during, and after treatment, as well as other vital signs like pulse and oxygen saturation before discharge. It's also not recommended that you drive until the next day. Patients usually use Uber or a family member to get home safely. Poll question, what do you think the process is for taking Spravato? We'll put some time on the clock.
So the first two options are the patient self-administers the nasal spray. The medical staff monitors the patient for at least 2 hours. So we'll give you guys just a few minutes to take a look at that poll and get your responses in. All right, so it looks like the responses are in. And I can't see all the way to the bottom. Shoot.
It is very small.
Yep. All right.
Okay, well, let's just show you. So we have a device here and a statement to read.
A little closer.
This sprayer does not contain medication and is intended for demonstration and training purposes only. Spravato is available by prescription only. That could be a commercial.
Yeah.
We will pretend that this is the first treatment. This is one of two 28 milligram devices that Trevor will use today. There's no need to prime the device or just spray it into the air. Please don't do that. But you can see these two green dots here, if we can get it on camera maybe. That's probably good enough.
Yep.
These indicate that you have two identical sprays ready to go. You lean your head back about 45 degrees, you close one nostril, and you administer one spray to the open nostril. It should click. However, I will spare Trevor by not putting it in my nose before he does. It should click, then you sniff gently, and then you will switch nostrils. I will hand it over to Trevor so that he can try that process.
Perfect. Now, again, this is for training and demonstration purposes only. So I'm going to go ahead and put my head back.
Yeah, there's nothing being sprayed, just to be clear.
All right, and then I'll do the other one. And I hand it back to the doctor to verify.
Okay. You can see, after Trevor used the device, that both of the green dots are now gone. That means that both of our identical sprays have been used. We now store the used device over in a sharps container, which I won't walk to just now. That's it, guys, for the demonstration. Thank you for paying attention and for being a kind audience.
Fantastic. So do we have one more poll, I think, before we head to the live Q&A? So again, this is a very warm and welcoming room. So the last question that we have for the poll before you guys go to Q&A is, do you think you have patients in your Greenbrook practice that could be candidates for one of these two Greenbrook advanced treatment options? Now it looks like about 44% voted. We're getting those results in. So it looks like we have a resounding majority say yes, they do have patients that would potentially qualify. So thank you, Dr. Cole. So let's go ahead and head to the live Q&A section. Now, I just would like to remind everyone, we do have the question panel on your laptops. So go ahead and you can submit your live questions through the GoToMeeting. But before we do, to follow up on that poll question is, many of you in the majority said yes, you do have patients that are that would potentially qualify for one of these two treatments we covered, both NeuroStar TMS as well as Spravato S-ketamine. And I just want to show you how easy it can be to refer your patients to one of the Greenbrook centers, likely in your area. It's very easy. First is identify those candidates, and then you complete the simple referral form. They've made this very convenient and easy from both the input of existing referrers and a lot of the providers that they currently work with. So I do recommend that before you leave the dinner or while you're in the room right now, go ahead and scan that QR code to see just how easy it is to refer one of your patients into a Greenbrook center. And then number 3, Greenbrook will take care of coordinating and keeping you updated throughout the care plan. So what's great is you guys work together to make sure that your patients do the best they possibly can. And Greenbrook does an excellent job of letting you know when they start treatments, as well as when they complete treatments with that update on their results and outcomes. So hopefully you've had an opportunity to go ahead and scan the QR code. I would bookmark it if I were you, just so you got it very close by. But we're going to go ahead and look through the important indications and safety information here, and then we'll go ahead and get started with Q&A. So I'm going to pull that up while we're going through these so I can take a look at what questions you've got coming in. All right. So, Dr. Poole, I've got our first live question in from Aaron, which is, if a patient experienced side effects, would you continue medication or wait to see if they resolve? Now, this is for medication, so this may take you back to when you're doing med management.
Sure, or if they, I guess if they're on Spravato at the moment, right? It depends what the side effect is. We have a few options with Spravato. Like I said before, it's a medicine that should rise in your system quickly and then come down quite quickly too. So luckily, a lot of the problems that might come on while you're in treatment should dissipate pretty quickly. We can always just observe. Other than that, we have 2 dosage options, like I was saying, so we can always spread treatments out. We can always try a lower dose. We can always just stop treatment and wait for a little while. Again, it just depends on kind of what side effect we're talking about and how meaningful it is. And let me just kind of create an example. So if it's nausea, for example, which can be a common thing, maybe something like 10–20% of people might get a little nausea. We usually first just look at if you ate, right? If you got a Big Mac sitting right on your stomach right before treatment, it certainly can increase the risk of something like nausea. So we usually have patients in that instance probably not eat for about an hour or 2 before treatment begins. Don't have a full stomach before you go into treatment. But if it's something a little more serious, maybe that is something that we'd reconsider and take a break from treatment.
Awesome. Yeah, I think that answers it very well. So the next question we got in from Caitlin is, can clients receive TMS and Spravato during the same course? Example would be TMS on Monday and Wednesday, Spravato on Tuesday and Thursday.
Yeah, they can. I have one safety concern about that, but it's just a scheduling concern that kind of mitigates that risk. So the most important thing I think of as a doctor is that Spravato can lower the seizure threshold ever so slightly, making it a little bit easier to have a seizure. Now, normally you wouldn't have one, but if you went and did TMS right afterwards, right, which is a treatment that has a risk of seizure, even though it's very rare, right, you would increase that a small amount by doing Spravato right before TMS on the same day. So we have patients flop that on their schedule if they're doing treatment on the same day, so that they do TMS and Spravato. It eliminates that unnecessary extra risk. Other than that, really it's just a conversation between the patient and myself about information. I think that's one of the trade-offs when you use 2 treatments together at the same time, right? You lose a little bit of info about which treatment is most helpful, which treatment is benefiting me, and also which treatment might be causing an issue or a side effect. But a lot of patients are okay with that trade-off. Just depends on what their goals are.
Yeah. Now, would you ever consider like the treatment gaps with trying to spread out both treatments? It kind of creates more variability in the outcomes of the patient, and ultimately trying to decide, let's go through one course of one treatment modality and then maybe switch to the other. So that way you can kind of isolate it, like, did it work? Was it effective? And then let's go ahead and switch to another variable.
Yeah, as a scientist, it's always the preference, right? I would love to just change one variable at a time if I can, right?
Yep.
So typically that is what we do. For the vast majority of patients, we'll start one modality, whichever one they feel more comfortable with or fits best with their schedule, covered by insurance, whatever it is, right? We'll try that one and see how well it works and how they respond to it. If they respond great, we won't worry about doing anything else, right? If they respond poorly, or they're one of those rare people that it just doesn't work for, right? We can always transition to the other treatment if they're a candidate.
Yeah.
But we usually talk about stuff during the first visit too, as a plan, just in case.
And Dr. Poole would like to elaborate on that question as well. I mean, if you were to choose one of the treatments, maybe TMS as the first line option in that case, how many times have you experienced where a patient actually had negative effects from one of those treatments?
It's not that common.
Yeah.
Especially if we're talking about TMS. TMS is really a minimal side effect neutral treatment. I didn't mean to scare you if I talked too at length about some of the possible issues, but I wanted you to understand what they were and how we mitigate them. With TMS, the biggest one really is discomfort, but we have lots of ways we can adjust to improve on that. Mm-hmm. It's very rare that a patient would have to stop TMS because of something like discomfort, and that's the most common problem, right? Discomfort or some headaches or something of that nature. With Spravato, kind of like what I was saying earlier, it has this list of side effects that are possible, but patients do need to know that it's really that they exist in kind of that 2-hour treatment window when the medicine's coming up and then going down. So it's not something that most people worry about for very long. They're not usually having problems at home or on a daily basis like you might from a medicine that's just sticking in your system every day or that you take every day.
Perfect. No, I think that covers it. And the only reason I think of that is because in the recent publication around the adolescent patients, there was over 1,200 patients involved, and less than 1% of them had a negative effect from the TMS, which was fantastic. So, you know, outside of the great outcomes that they were able to capture in that study, you know, that less than 1% had a negative outcome was awesome to hear.
It's what I've seen in the data on adolescents too, that essentially the safety and the efficacy are very similar to the adult population.
Mm-hmm.
Good to prove to ourselves.
And I love your insights too, actually, having witnessed this within the patients. This next question is, I would say a little niche, but it's coming from Jakaria, is can patients with substance or alcohol abuse take Spravato? And maybe this is, how would you handle a patient that has substance or alcohol abuse, you know, that would likely be a candidate for Spravato?
Yeah. I think about this in a few ways, maybe like 3 steps. The first step would be screening, right? So like we were talking about earlier, they'll have the pre-assessment with me, the provider evaluation with me, where we're screening all along the way and asking, of course, about substance abuse, including just a history of substance abuse, not even anything active, right? Once we know that information, really, if they do have a history, I want to know about their sobriety if they're currently sober. Usually we do want, before starting something like Spravato, for a patient to be meaningfully sober. What do I mean when I say that? Well, it depends on the substance, right? But at the least, I would say at least a month of sobriety, right? I also want to just know that this is MDD, right? And if somebody's using a substance that can cause depression on its own, I don't know that yet. So at least a month, but the longer the better. We prefer 3 months, 6 months, that kind of stuff. We'd also prefer it, and I ask about it often, what kind of structure you have in place to help maintain that sobriety? How motivated are you, right? I want to be able to document that stuff as well for myself to understand the risk, right? Are you involved in an NA or an AA program? Do you have a therapist? Do you have a family around you who can be supportive and be an observer in the home, that sort of thing? We can always do the medical thing too. We can always just ask for a urine drug screen or a test in a lab. Mm-hmm. What are the other 2 steps? I think the other one is, if you do decide to start treatment, just monitoring, right? For patients with a history of this kind of thing, monitoring for any cravings, any behaviors that are indicative of that kind of problem. Certainly any intoxication when people are coming in, you know, if they seem bizarre or they're acting like they are intoxicated, we always can stop treatment right now. We always don't have to start. Myself and staff have actually done that a few times, a handful of times. Luckily, it's not often.
Yeah, and I would say, and you know, that was one of the great things about the care team here at Greenbrook is that they're likely to you know, catch that before treatment's administered, and obviously they probably do their, you know, pre-qualification questions before treatment starts every day that those patients come in.
Yeah, I think something else that's just critical to point out, and since I was already putting this into a 3-step mold, it's the 3rd step, right? But I just think about the likelihood of abuse or misuse with Spravato being quite low, and why is that, right? Well, I think it's because of this REMS program, right? And the fact that you use it only in a supervised fashion, right? The medicine comes from a certified pharmacy. It comes to us as a certified clinic. We store the medicine here and tell you when it's ready. You come here and you use it only directly under our supervision, and then we take the used medicine and put it in a sharps container. So the patient is never in private possession of this medication. It really lowers the chance for abuse and misuse. The other thing as well is the controlled dose and the controlled frequency also just limits the possibility for tolerance and dependence, because you're not using it every day at uncontrolled dosages, right? Not using it at home. So hopefully that quells some.
Yeah, I think I thoroughly answered the question. So we've got a bunch of questions that are just streaming in right now. We're going to try and, with about 10 minutes left, let's try and get some fastballs thrown out there. So what is the effectiveness of OCD, coming from Mitch and the team out in Maryland?
So for that, I assume you're talking about TMS,
yep.
Which is approved for OCD. I would say that it's a little bit less than depression, but it's still pretty up there. It's somewhere between like maybe 40 and 60%. The number I saw most recently was 57 from a big study, 57% response, right?
Yep.
That's pretty good.
Yeah.
You know, these are people who have failed a medication or 2 for OCD already. They might have failed like exposure and response prevention. To do those kind of numbers in that population.
Yeah, when they have severe depression, obviously that's a major effect on their lives and the quality of life that they have. And I think the way that, you know, they look at that 50% reduction. They look at 30% reduction in symptoms, and about 50% of patients do respond to that. And I would also say it's a great option when they're also doing adjunctive therapy, because with the OCD treatment, it is an adjunct treatment, and so keeping them in any kind of therapy, I think, really helps them. So this next question is going to be around bipolar. So have you, or what's the ability to treat patients bipolar with heavy depression symptoms, and how do you handle that? And it may be a reimbursement concern more than anything.
Depends, right? So first, they'll meet with me, right? We talk about this in a lot of detail. Certainly, I have many patients who maybe they picked up a bipolar diagnosis a long time ago. Maybe what they mean is more kind of in the moment mood shifts, but not necessarily clear manic or hypomanic episodes that meet DSM criteria. If we don't feel like that's the case, I often will just diagnose a person with depression, especially if, like the question is maybe implying, they've had solo depressive symptoms for the majority of their illness and maybe only very limited evidence of anything like mania or hypomania. So often we can change that diagnosis if we think it's true. We can consult with the psychiatrist who sees them now, the therapist who sees them now if we need to, pull some records, pull hospital records. But that's the first step, is just making sure the diagnosis is right in the first place. After that, if it really is bipolar, for patients with well-controlled bipolar depression who really just experience the depression side, TMS has been shown to be quite safe and effective for those people. We've certainly used it as an off-label treatment here every now and then, got some really good success. So I'm glad to try it. Often with the insurance, the practical side of things, I do have to write some letters to people. But we've done that and gotten people to be successfully treated. Self-pay is also an option for people.
Yeah. Oh, that's awesome. I think that's huge that, not only the providers at Greenbrook, but also the staff are willing to, put in the effort to really fight for those patients and get the best treatment that you can offer. So I know this next question, I experienced a few pulses where we did a quick mapping procedure, and you alluded to, headaches and the side effects of TMS. So this question from Mitch and the team is, are headaches a typical side effect of TMS treatment? I think we covered that. And if so, how severe and how frequently do patients experience these headaches? And I know that they are transient in nature. They may seclude that same day or maybe a few minutes after treatment, but what has your experience been with the severity and how frequently?
So I always ask people if they have headaches. I think it's just good to get a baseline before they even start treatment, right? To just understand. If you normally have a migraine once a month, you'll probably still keep having a migraine once a month, and it has nothing to do with TMS, right? So I like to know their baseline first. For people that do get headaches, that's kind of a new thing to happen with TMS. Maybe I'd say about 20% of patients, 1 in 5 people, are going to get something like that. Okay. Like I was alluding to earlier, it's really isolated the first week or two as they're adjusting to the power level and kind of just having those muscles being stimulated for the first time. You don't normally work them out, right? So this free workout is kind of hitting them a little hard. Yep. But if they do get headaches, like I was telling you, ibuprofen, time, a little bit of sleep. And the time part is important because you do accommodate to treatment. As you go some days of doing it, it does get a little bit easier and a little bit less painful. Headaches do tend to dissipate. It's quite rare to have them later in treatment or even at the treatment midpoint. Yeah. I seem to care about them far more than patients do, by the way. I ask about them all the time. Patients say, yes, I have a headache. I'll go into it. They'll say, oh, by the way, Dr. Boyd, I don't care. I want to keep doing this. I don't care about them, just so you know, Dr. Boyd.
Well, and while we're on the subject of side effects, I want to go back to also contraindications. And I know you covered this, and I know the answer. But is a pacemaker contraindicated for TMS?
No, it's not an absolute contraindication. So you can have treatment with a pacemaker. I'd say that's more of a discussion that I have with the patient's cardiologist, right? I want to know how recent it is and what they think. Really, I just want them to know about TMS, what it is, how big our magnetic field is, even the weakest parts of it, right? But in actuality, it's pretty low impact on something like a pacemaker, even if it is made out of metal. The bulk of the TMS field, even the weakest parts, are about 12 inches, so rarely does that extend into the chest. If anything, it's similar to the force on the chest from gravity itself, right? So I don't have many concerns about that, but as part of due diligence, I do often do some calls. Yep. We just screen and just let them know what's going on. Good to be in communication.
Well, and I think that's important for that physician evaluation that you guys do here at Greenbrook, and spending the time to do the due diligence to see do they qualify, and then making sure you're following up with any of their other physicians as needed. So let's switch gears back to Spravato for this next question, which is, what are the interactions with Spravato and other medications? And I know it just recently got the indication moved to monotherapy. So obviously it is an adjunctive treatment with medications, but is there any interactions that you're aware of or any concerns there?
I assume they're talking about negative interactions, and that is possible, right? So I think about two main effects. I think about for people that take like a stimulant medication, if they were to use that kind of right next to Spravato, maybe they'd be peaking in the system at the same time. And there is a little bit elevated risk in that case for the blood pressure going a little bit higher than we might expect, right? So we usually just have patients avoid it, right? It's Adderall. It's not generally going to hurt somebody to avoid it, right? But we have them just skip treatment that day with their Adderall. It's a kind of a low attention day anyway. You're hanging out here. So we usually just have them avoid the medication if they can. But even for folks who have taken it, it doesn't seem to be that big of a concern as long as the dose is not too high. The other interaction I think about is more of one for sedation and respiratory depression. That's for people who are using like benzodiazepines, opioids, that kind of stuff. I'm sure we have many patients using those, so do I too. Again, it's about kind of avoiding the peak dosages, right? If they're on too high of a dose, getting them to lower it a little bit if they can. If they can't, spreading it out, right? Making sure that we're using that opioid or that benzodiazepine several hours before or several hours after, but not right on top of Spravato so that their peaks don't align. It just mitigates a lot of risk and helps to keep people safer.
Yeah, no, I think that makes a lot of sense. Now let's switch back to adolescents and TMS, which is what's the youngest age you can treat? And what about teens with treatment-resistant depression and high suicide ideation?
So it sounds like a few questions at once. I would say that the youngest for the FDA indication is 15.
And what about Spravato too? Because I think it's a general question.
So Spravato is just for adults.
Yep.
We don't treat children with Spravato. It's not part of the indication. But children with TMS, 15 to 21, that's not really a child anymore, but 15 to 18 or however you want to count it. 15 is kind of the youngest age we work with. I think the youngest I've done has been 15, and maybe a few 17-year-olds who was right on the edge of adulthood, right? But certainly they had good results, and in general, like I was saying earlier, the efficacy of Spravato, of TMS, the efficacy and safety of that seems to be the same kind of across the board from adolescents to adults to even folks in late life depression, 70s, 80s, 90s. Mm-hmm. Results seem to be very similar. I'm not saying the numbers are exactly the same, but within 5 or 10% of each other in terms of response remission. Safety, same thing. In terms of, I think the last part of the question, increased suicidality, a concern often in adolescents who take like a new antidepressant. That doesn't seem to be something that happens in TMS like it does with antidepressants. Even though it's something like I talked about earlier, we still watch out for it just in case. We see patients every day for that purpose.
Yep. And so that's excellent, that we do have that availability to treat those patients. And then obviously Spravato becomes an option when they become adults. And a lot of that's driven by their insurance policy. But again, something that will be evaluated as those patients come in to Greenbrook. But Greenbrook is absolutely willing to treat those 15 plus patients.
Yeah, gladly, please.
So we've got one last question. I know there's several questions in the queue right now, but we are at time. And so I'm going to hit this last one. And hopefully you all remember everything that Dr. Poole and Savannah covered in this webinar. And we hope you take away a few key things about, who would be considered a candidate for either Neurostar TMS or Spravato as ketamine, and, how accepting and willing our team is here at Greenbrook to accept those patients and, make sure that they have the best care and compassion as possible. So this last question from Adrian is, does it impact memory? And maybe we'll answer this two ways. Does TMS impact memory? And what have you experienced from Spravato and memory?
So I will say that for TMS, we are targeting the dorsolateral prefrontal cortex, which does play a role in concentration, which plays a role in memory, both short and long term. No negative impact from TMS in memory, not that I'm aware of in any clinical study or larger literature. Nothing I've seen anecdotally here in the clinic either. If anything, there does seem to be a mild positive benefit, right? We know that severe depression has an impact on concentration, an impact on memory. People getting treated with TMS seems to benefit memory. For some patients, particularly older patients, we've seen a couple like pseudodementia patients, people with MDD and cognitive issues, and the cognitive issues have improved as the depression has. Does Spravato affect memory in a negative way? That's a big concern that, doctors are always looking into how medicines affect certain things like cancer, heart issues, or things like memory cognition long term. We just completed a big by we, I mean science, right? A big study of Spravato long-term, something like 5, 6, 7 years, however long the medicine's been around. So far, there doesn't seem to be any long-term cognitive impact, even with repetitive use throughout that period for years. So again, just a positive thing.
Yeah. Well, I think, memory, and we hope you all remember everything that we covered today. So I thought that was a great question to end on. So with that, we thank everyone that's attending our live awareness events across the U.S. And I just want to thank, Dr. Poole. We appreciate everything you covered today. You are a wealth of knowledge and obviously very compassionate about patient care and doing what's right for your patients. I want to thank Savannah for covering the consultation. I hope you all have an opportunity at those live events to engage with some of your local and regional consult coordinators and the staff here at the Palm Beach Gardens Greenbrook. If you haven't, I would highly recommend you work with that local Greenbrook team and hopefully get a chance to visit, maybe experience, the motor threshold with a TMS device and see, what kind of care your patients in your local community have access to. So with that, I'd like to thank everyone again for joining our Greenbrook Gatherings webinar series, and we hope to see you on our next one, which will be October 29th. And we'll be out on the West Coast thinking about covering a little bit about treatment options and what patients experience during treatment, as well as what they can expect after treatment's completed from the Greenbrook staff. So we encourage all of you to register for our next event and look forward to seeing you all on the next webinar. Thank you, everyone.